of the I'm a member of the COVID Action Steering Committee. I'll be chairing the first part, the first hour of the meeting tonight anyway, but then I've got to go off to another meeting. Just a few points to mention before I introduce the speaker. We have closed captioning enabled, so you can access that via the CC button. Plus, it says here, Otter via the live button. I haven't got a clue what Otter is, but I've been told to say it. So that's available via the live button. I presume that's working, is it, Joan? Yeah.
I'm not sure it is. We need to talk to Noah about that outside the meeting.
Okay.
It used to be working. It might have been disabled by now.
Okay, but the closed caption is working. If you can use chat and or electronic hands at the bottom if you can, when you want to speak later on. We will be recording the call, but it won't be live streamed, and it will be available on our website in a couple of days, basically. The view will only show the speakers, not the gallery, just to make the point. But if you don't want to be recorded, can you just let us know in the chat? Keep your video off, and just change your name on the front, if that's okay. If people could stay mute, I think these are the things people know now, unless you're speaking. And if you can, if you can turn your video on when you're actually speaking, that would be really good. Particularly if there's people who need to lip read. I think that's everything. Okay. Right. This evening's speaker is Jonathan Fluxman, who's a retired GP, and he's on the organising group of the COVID pledge campaign, and he's the COVID lead for Doctors in Unite. Jonathan's going to talk about the campaign for safe healthcare, and you'll also be looking at the still high levels of ongoing transmission, which is everywhere, and the resulting infections and reinfections, which obviously affects all of us. Jonathan's going to speak for between 15 and 20 minutes, and that will be followed by question and answer session, and contributions from the floor. So over to you, Jonathan. Cheers.
Thanks very much, Frank, and thanks again to COVID Action for inviting me, and for the great work you've been doing really from the get-go. It's really great to be back among friends and like-minded people. Okay, I'm just going to share my screen. There we go. I hope everybody can see that okay. Great. Okay, so what I'm going to do is just go through initially transmission, because I've been finding lately that there's still a lot of misinformation about transmission. I think we've won the battle on airborne versus droplet, more or less, except if you're a member of the infection control community or you're an epidemiologist or a public health doctor, I regret to say. But I think by and large, the community out there and most people accept that this disease is airborne. But there are some issues around the nature of airborne transmission and its dynamics that are important. And then I wanted to get on to talk about the campaign for safe healthcare, which is a joint campaign between the COVID pledge group and the clinically vulnerable families group. So I'm just going to crack on. Okay, so I mean, this diagram may be familiar to you. I've tweaked it a little bit. This is from Lindsay Meyer, famous and well-regarded airborne scientist. Near field airborne transmission, and then further away in enclosed, poorly ventilated spaces, super spreading to lots of individuals. This is really important, and it is at the heart of everything we need to understand and do about this pandemic, and unfortunately is not what is being done, and that is why we remain in a mess. and why we have not actually had a discernible impact on this virus. Oop. So the great majority of transmission occurs in these settings, which lots of people which are poorly ventilated. And the epidemiological studies that were done really quite early on showed this very clearly. This is a wonderful study done in India, over 500,000 people. And it showed that 5% of individuals account for 80% of cases. And 70% of infected people don't go on to infect anybody else. So if you think about that, that really determines and informs the way this pandemic actually spreads across the globe. This is another US study which showed pretty similar numbers. And there's lots and lots of papers which talk about the importance of super spreading as the main driver for the pandemic itself. So what does this mean practically? I think a good analogy is super spreading is like a cluster bomb, you know, that terrible weapon that they use in warfare. One device which explodes and releases lots of little bombs, which then explode and kill or maim people. So here you have lots of little devices having been released by the main device, if you like, and these are secondary outbreaks of spread. The policymakers seem to think that this is how COVID spread, 1-to-1 or 1-to-2, 1-to-3 people. It's simply, obviously that does happen, and it happens a lot in households, but that is not the major route or the major dynamic of spread. And if you think about it, the rapidity with which the SARS-CoV-2 virus is spread across the globe, especially Omicron and subsequent to the advent of Omicron, it cannot explain the rapidity of it. This is an early study of a call center in Seoul in South Korea. 44% of workers in that call center who shared the same indoor space got infected within a few days of each other. And this absolutely typical epidemiological graph of cases showing super spreading. That was an early indication of the nature of the SARS-2 pandemic. This is near a home, Northampton, the M&S sandwich factory. Same typical outbreak in epidemiology. And you had over 300 workers infected at the end of the day. And of course, what did management do? They blamed the workers for not socially distancing or smoking together during smoke breaks or sharing transport. And shamefully, the director of public health agreed with that, when in fact, super spreading was quite obvious. This is another example in a school in Mede in Italy. You see these little bomblets, if you like, where you have one infected individual infecting 10, 12, 15, 20 or more people. This is a new study, very recent study from the US, I believe, showing the importance of schools and children as drivers for the pandemic. Sorry, it's a bit of a busy slide, but basically what it shows, the orange part of the graph shows that the index case in households, in other words, who brings the infection into the household, is overwhelmingly children. Over 70% of households, the child was the one who brought COVID into the household. This is another school study, again in South Korea, which shows very beautifully how the schools, kindergarten schools, there was, I think, a taekwondo class that the kids went to, and shows these super spreading clusters. And then, you know, there's the primary infection from there and secondary after that, and it spreads out in waves. This diagram is very telling. This, in fact, is not from SARS-CoV-2. This is from MERS in 2015. People may know that the MERS virus is another coronavirus, quite similar to SARS. And this was a study done in a couple of, or 3 or 4 hospitals in South Korea during their MERS outbreak. One person went to Saudi Arabia, brought it back, and this is what happened. So I think that was the index case, infected about 25, 30 people there. One of those people went to an A&E department in a big hospital, stayed there for 2 days and infected over 80 people, several deaths of patients and staff. And then there were other smaller super spreaders here. So that's how dangerous A&E departments, emergency departments in hospitals can be. They're busy, they're noisy, people are talking, kids are crying, there's lots of aerosols in the air. And the analysis of this outbreak was poor ventilation, overcrowding, driving the pandemic. And there was no masking either, I believe. And you know, I'm getting sick and tired of hearing, oh, they didn't get it at school or in the hospital or in the workplace, they got it in the community. And I'm sure, you know, many of you on this call have heard the same thing. And it's simply not true. It's quite clear that congregate, poorly ventilated spaces are where most transmission happens. And then people take it home and into other environments and spread it from there. And the lesson from that is if we ventilate and clean the air in these congregate spaces, we will really impact very significantly on transmission. It's difficult to say how much at this point, because Omicron now is so infectious that it's difficult to know. But look, it's still an airborne virus. If we clean the air and we wear masks, the virus will not get into our respiratory tract and we will not get infected. Now, the scale of infection, I think, is very important to appreciate. The degree of the scale is actually enormous at this stage. This is a graph from Independent Sage towards the back end of last year or early this year. And what these graphs show is that, for example, here in, this was early 22, 60% of primary school kids were infected within about a month or two of each other. 60% of our primary school kids. In the second half of 2022, about half the adult population was infected. Now we know now that we're moving into a situation where we're not so worried anymore about people getting infected because probably all of us or nearly all of us have been infected. We're now into the territory of getting infected and reinfected again. And this is a chart which is now 6 months old almost, and it showed that 40% of infections are reinfections. And this was a study very recently, it came out from Brazil, showing a triple vaccinated healthy male in his 50s was reinfected within 16 days of a primary infection. It was a well-conducted study. They did genomics analysis of his infections, and they found 2 different variants. So that has profound implications because it means that the immunity from vaccination is not very reliable. Look, this is an outlying case. I don't want to make out that this is happening everywhere to everybody. It's not, as far as we know. But it shows this is what can happen. There are lots of papers showing now that reinfection within 2 and 3 months is very common. So much so that researchers are actually calling for the definition of reinfection, which now stands at 90 days, needs to be changed to take into account. So going forward, we're all looking at 2 or 3 infections a year, or more probably. There was a very interesting talk on Twitter recently where a physicist who'd done some mathematical modeling, and he reckons that the reinfection rate is determined by how quickly how antibody levels wane after either a previous infection or a vaccination. And if that's at 3 months, we'll get infected 4 times a year. If it's at 6 months, we'll get infected twice a year, and so on. So we're looking at constant reinfections. And this really matters. The government would help us, would have us believe, oh, it's just like a cold, it's just like the flu, and I'm sure you've all come across this time and again, unfortunately, even by our national broadcaster, who put out blatant misinformation and refused to correct it when challenged, that COVID is just like the flu, in fact, less harmful than the flu. But this is the reality of what happens. This is a very important paper, which shows that subsequent infections, this is after 1 infection, 2 infections, 3 infections, all these lines are going in the wrong direction. They all go up. After 3 infections, you've got an 8 times higher hospitalization risk. And all of these are different organ systems and bodily functions that deteriorate, get complications, and so on. And we've all heard these anecdotal stories of younger people, middle-aged people, and generally fit people getting severe complications, and some of them drop dead, and many of them get long COVID. People may not know there is a long COVID group for endurance athletes. Okay, this is people who think nothing of cycling 30 miles or running a half marathon. The membership now stands at 1,400 people. So this is not a disease that is confined to clinically vulnerable people and so on. Anybody can get it, and we are all just 1 infection away of being disabled by this virus. It's nasty, and that's why infections matter and why we need to mitigate them. The risks of long COVID, we all know about. WHO recently said it's 10% with each infection, not per person, each infection. Another recent study showed a 20% risk on reinfection, and another further study on children showed that it's about 12% on a first infection, about 16% on a reinfection. So that immunity from previous infections doesn't stop the kids from getting long COVID. Now, these are not absolute numbers because, as always, you've got to have a control group, and the control group had 4.5% of them had symptoms. Okay, but still that shows a significant increase in those symptoms amongst children. And we now accept, most people now accept, that children get infected, they can get sick, they can get long COVID, that they are major drivers of this pandemic. This is a good way of showing what long COVID in relation to deaths and hospitalizations, which is always what the minimizers concentrate on when they are willing to talk about COVID any longer. They're so busy burying it, but when they do talk about it, they will acknowledge that there are some deaths and some hospitalizations, but they very seldom refer to the hidden iceberg of long COVID under the surface. So coming on to the campaign for safe healthcare, as I said, this is a joint campaign between ourselves and the COVID safety campaign and clinically vulnerable families. Here's the website address. If you'd like the slides afterwards, excuse me, no problem. I happily make those available to Frank and Joan, and they can circulate them. Just before talking about what the campaign is about, excuse me, I just wanted to run through quickly how protections and the basic principles of managing infectious diseases are being dismantled before our very eyes. You know, not only is the NHS being run down and privatized before our eyes, and many of you may be involved in campaigns like Keep Our NHS Public and so on, which are fighting very hard to preserve the NHS from being systematically run down and privatized. But the actual principles of disease control, which have been in place for, a century or more, are being thrown out the window. So masks are no longer required, okay, except for certain settings. I won't go through all the detail, it's all here. But these are being done away with on the say-so of our old friends, the Infection Prevention and Control Cell, who, to my mind, are guilty of a massive crime against the population in this country, both healthcare workers and patients and the general population. But we would ask that all visitors continue to practice good hand hygiene, of course, by washing their hands on arrival at the hospital, as if that's going to stop an airborne virus. And the chief nurse said, oh, there's going to be some anxiety, but there'll be masks available for those who wish to wear one. This individualizing of risk and protections is simply a non-starter in terms of disease control, infectious disease control. You have to protect everybody otherwise it fails. Waiting areas are particularly risky because they're crowded in hospitals, GP surgeries, and so on. This picture is important. I just wanted to refresh your memories about it. Note this is an FFP3 mask. I would urge all of you to get one if you don't have one. Don't get masks with ear loops. The fit is not good enough. The seal around your face is not good enough to protect against Omicron in particular. Get one with head straps, and do get an FFP3. Please don't wear a surgical mask. They aren't good enough. If you've got an FFP2 with ear loops, please upgrade it. Look, it's a lot better than nothing. And some people can get a good fit with ear loops, but the perceived wisdom is now move away from those and get a mask with head straps. And please wear one when you go on public transport and when you go into healthcare settings if you have to, and any other crowded space. What else has gone? Testing requirement for staff has essentially gone. There used to be asymptomatic testing of all staff. Now that's gone out the window. Again, here the new guidelines, and effectively testing is a small number of situations and members of staff. Testing for patients has gone the same way. We used to routinely test all patients who were on admission to hospital. Makes good sense, you'd think. No, they stopped that. What was the result? Surprise, surprise. Stopping universal admission testing in England and Scotland was associated with a significant increase in hospital onset SARS-CoV-2 infections. And here are the graphs to show it. Here's when they stopped testing, and you can see the jump up in the hospital-acquired infection rates. What else has gone? Our genomic surveillance, which was really world-leading. I don't like to use that term. It's something that the Tory government is very fond of. Britain's the world beater at this, that, and the other. But actually, our genomic surveillance system was excellent. And that's been effectively dismantled now. We're testing a very small number of samples, and the infrastructure to do it has basically been dismantled. And that's bad news, because we can't test and we don't know what's happening with variants anymore, except for a small number. Are those numbers typical and representative? We don't know. What else has gone? The ONS infection survey, again, probably world leading, where we sampled regularly a representative number of patients of people who were not symptomatic. It was just a random sample, statistically random sample of people in the community, and it gave us a very good idea of what was happening to COVID in the community. That's gone. It stopped at the end of March. So just to come on to the campaign, I mean, we can perhaps discuss in the Q&A why these things are being dismantled, but I'll leave that till later. So what is the campaign for safe healthcare? It's aimed principally at clinically vulnerable people, but it actually does apply to all of us. I would hate to have to go to hospital at the moment. I'm healthy, I'm lucky, but if I were to go into an A&E department, the risk of getting COVID is significant. So it's aimed mostly at clinically vulnerable people because their risks are significantly greater. So there is a letter template to help people challenge their healthcare provider and ask for mitigations, like everybody around them being masked, other patients and clinicians. There's a fact sheet about the pandemic, much of the stuff I've been talking about and more. There's a guide to how to fill in the letter, how to make a complaint through PALS, how to escalate the complaint, and importantly, to challenge this increasingly common phrase that we are hearing back from hospitals and other providers: oh, we're following the guidelines. And every time I hear this, I want to punch the wall. These are the famous guidelines. They still do not recognize airborne transmission. Still, 3.5 years into a pandemic. They're still based on unscientific beliefs in droplet spread. I counted the other day, there have been 54 revisions of this guidance since the beginning of the pandemic. You might think it's a good thing they keep revising it to stay up to date, but there is not a single one of those iterations of that guidance that talks about airborne transmission and puts it in its right context as being the predominant means of spread and the means by which we need to tackle that spread. So they are really a complete waste of space. They are not fit for purpose. And every time you hear that, please challenge it. Have a look at the website. There's quite extensive documentation which really examines the guidelines in detail and refutes all the nonsense that they spout about hand washing and so on. Cleaning of surfaces and hand washing are important. Please don't misunderstand me. They are important infection control mitigations. But without airborne protections as well, they have signally failed, and we've seen how they've failed to stop the transmission of this virus. And we've seen what's going on in hospitals. I haven't included it here. 30% of infections of people with COVID in hospital got it from the hospital. So just to finish then, personally, I believe the campaign within healthcare to provide safe healthcare is very important. Hospitals and other healthcare settings are really the last place where there are any kind of collective mitigations in place. They're doing away with them systematically. But if we lose this, if we can't defend this in hospitals, I think our chances of getting COVID mitigations elsewhere is much less. People will be able to say, oh, but look, in hospitals, they don't even need them anymore. They don't wear masks anymore. So I think it's very important, quite apart from the fact that it's a crucial step. So what can we do about it? Well, I think it's quite a promising campaigning area because, looking at social media and conversations with friends and family and other people, people understand that hospitals and healthcare are different. They are much higher risk, and it's important that we mitigate that. So what are the things we can do? There's a petition here. If anybody hasn't signed it, please do. It's only got about 5,000 signatures, which isn't great, but the link's here. Please do sign it. Some other ideas, perhaps a local demonstration. The London and Southeast region of the UK Health Security Agency is in Waterloo in London. We could stand outside and shout at them with placards and things. People who are clinically vulnerable won't be able to come, but those of us who can, we could read out messages. There've been some great demos in the US like that. Please challenge your GP to provide mitigations. Something we might want to take up is an air purifier, an air cleaner in every waiting room, for example, everywhere. GP surgeries, A&E departments, within and without healthcare. Just by way of finishing, sorry, I've gone on over time, just to remind you that our greater, well, how can I say this? The great and the good that basically run the world, this is what they have when they meet. And it's quite clear that they protect themselves really well. This was at Davos at the beginning of the year. They had PCR testing to enter the venue, the conference. Anybody who was positive or didn't have a test was barred. There were HEPA cleaners in every room, and they had state-of-the-art new ventilation systems installed. This is Tedros Ghebreyesus, Director General of WHO, sitting and talking to somebody with an air cleaner in the same room. This is the same chap sitting with Mike Ryan in February 2020 when he said, COVID is airborne. Mike Ryan then whispered something in his ear and scribbled a note, and he said, oh, sorry, it's not airborne, it's droplet. I meant airborne in the military sense. Work that one out if you can. Okay, I'll stop there. Thanks very much.
Right, thanks very much for that, Jonathan. That was absolutely brilliant as ever, very detailed and so on, and a lot of basis there for us to get involved with the campaign if we haven't done all already. Right, if anybody has got any questions or comments they want to make, if you can use your electronic hand, if you can, that would be great, because obviously can't see everybody. John Puntish got his hand up here.
Yeah, well, first of all, thanks very much to Jonathan for a very clear talk and great slides. I mean, one other thing that we've lost is the vaccine plans, so that the former chair of the vaccine task force has commented on that in the last few days, saying that that's left us fraught with danger in terms of not having an adequate vaccine response if there's a new pandemic, for example. And this is all part of the narrative, as you were saying, that it's all over and it's now no worse than a cold. And the WHO position, I think, is not on aerosol spread, but downgrading from public health emergency of international concern to a global threat. I don't think it's unreasonable, because what they say is that we've moved from an emergency situation to a long-term, having to have a long-term strategy, and warning governments that they need to keep up the systems that have been developed to protect us from COVID, that guard shouldn't be let down, that it hasn't gone away, and don't say it's not a problem, it's not an issue. And of course, all those things have been completely disregarded by our government. Can I just ask you one thing, Jonathan? Do you have any sense of what happened with air filtration systems in schools, where there was some money available, but not very much? It looked as if some schools were getting them, but I don't know what the current situation might be there, because actually putting them in schools had been shown, as you know, in I think in New York, to significantly reduce risk of infection. And you made some comments about how common infection was in school and then transmitted to home. So do you have any information about schools and HEPA filtration?
Okay, John, you want to come in with that? Yeah, I'm gonna cheers, Jonathan.
Do you want me to answer?
Yeah, if you could, yeah.
Okay. Hi, John. Good to see you. Thanks for those comments and the query. I agree with you. WHO's warning, when it stepped down from the status of global health emergency, was very clear. There's a significant ongoing threat, and the last thing government should do is dismantle the infrastructure. And as you say, it's exactly what we've done. The schools air filtration thing, unfortunately, the rollout was extremely problematic. It was limited by a number of things. One is the carbon dioxide level that they set at over 1,500 parts per million, which is way over what most experts think is safe. There was no resource, or very little resource. Schools were given CO2 monitors, but then I was directed to I think it was a Facebook group or something like that by, I think it was a teacher's assistant. And there were comments from people working in schools, and most of them said that the CO2 monitors were gathering dust in cupboards because there was no support about how to use them, and no clear guidance. And it was all the teachers were left to do this over and above their normal workloads, which is completely unreasonable. The air filter units that were supplied or recommended were very expensive. The money had to come out of school budgets, apart from a small minority of schools, such as those kids who were very vulnerable, educationally subnormal kids and so on. So it's kind of died a death. and I've heard lots of stories from parents in schools that the schools don't want to know. They even offered to pay for them, some of the better off families, and the schools are not interested because the narrative from government has been it's all over. Thanks.
Okay, thanks very much for that, Jonathan. Alice.
Thank you, and thank you to Jonathan for such an enlightening and informative talk. It's so refreshing to hear somebody of sanity and with genuine information speaking, because like myself, I'm sure all of you are bombarded by propaganda from all sides these days, and have been for some time. So I wanted to ask a couple of questions and just throw in my own circumstances and see what Jonathan made of it. Although I, consider that I'm pretty well informed about it all and have tried to be, I'm still not 100% clear in this difference between airborne, the airborne virus. I know for sure that it's airborne, but the whole business around droplets, because I thought that there was some belief that the spread was contained by the fact that the COVID particles were contained in droplets, so they were falling to the ground more quickly, and therefore an earlier belief that a room, for example, with air might remain infectious for longer because those particles were sort of still flowing around unless windows were open or it was outside. That situation wasn't mitigated, or was mitigated, if the droplets theory holds up. I wanted to ask you about masking and whether individuals wearing masks on enclosed environments such as the tube, where I found myself for the first time in ages a few times last week, helps or not. I've certainly complained about the situation in hospital where my mum, who's just turned 80, had to go. And not only were people not wearing masks, but even those who stepped through the door of the A&E, including my mum and our family friend, were told, oh no, you don't need to wear a mask, take them off. I phoned up to complain about that one. On vaccines, Jonathan, I had 3, all Pfizer, don't mind sharing that. The third one made me very unwell for about a month. I was kind of drugged. I haven't had another one since because I was worried it might not go, that particular feeling. So those are my thoughts, and I entirely agree with you about the crime against humanity.
Thanks.
Wow.
Yeah, if you want to come in on that then, Jonathan, thanks. Yeah, great. Thanks very much, Alice. So droplets versus aerosols. I just want to go back to that diagram, if you'll just bear with me. This one. Because I think this is it's fundamental to the problem and why we failed. So for, oh gosh, my keypad's too sensitive. So for a long time, it's actually been known that viruses, respiratory viruses in particular, and a number of other pathogens. There's a very good table which I'll add to this presentation. I forgot to put it in. There are about 20 pathogens that are very likely to be airborne. Mostly viruses, some bacteria as well. I mean, TB is accepted, measles is accepted, but influenza and SARS-CoV-2 and SARS-1, by the way, from 2003, no, those are droplets, according to infection prevention people. There is no basis for it. The science has been known for a long time. The aerosol scientists have been publishing papers since, for a good decade and a half. People like Lilia Moravska, Lindsay Marr, who I mentioned, Jimenez and others, to show conclusively that airborne transmission is significant. But IPCs say droplets, which are these big blue ones, right? They fall to the ground. If you think about it, in order to get infected with droplets, those big droplets would have to hit your eyeball, inside your nostril, or into your open mouth. That's the target area. Very small. The surface area of our lungs is the size of a tennis court. We breathe in and out about 15 times a minute. So it's these tiny ones, and obviously for the purpose of this diagram, they magnify it greatly, but they're tiny, of the order of 1 micron, 1, 2, 3 microns, and a bit less. So you breathe in and out that air, which contains all these aerosols. If it's poorly ventilated, if the CO2 level, for example, is 1500 parts per million, 3% of the air you're breathing in comes from other people. So that's 1 in 20 breaths you're breathing in somebody else's expired air. It's like drinking the backwash from somebody's drink, if you like. Sorry to be gross about it, but I think the analogy is quite opposite, because it, we obviously demand clean water, but there's something about demanding clean air that for some reason we can't do. So I would discount droplets for the purposes of infection control. Although cleaning of surfaces in hospitals is important, and interestingly, not because you touch things and then touch your mouth or your nose or your eyes. What happens with the virus on surfaces is that they become aerosolized again by people walking past on the floor, or people making the bed. The housekeeping staff, they will sort of pull the bedding off, and the virus then becomes aerosolized into the air again, and you breathe it in. So actually surface spread becomes airborne as well. Very interesting tweet that from one of the aerosol engineers. So let me stop that. Your other questions very quickly. Yes, it helps wearing a mask on the tube. Absolutely, it does. And going into a hospital, it's not as good as everybody else was wearing it. But look, if you're wearing an FFP3 and it fits really well, it will stop the great majority of viruses going in. And if you've been fit tested and the seal is 100%, you're very likely to not get infected at all. Actually, one patient, I went along to a meeting with her, Zoom meeting with her infection control team at her local hospital. They offered to do a fit test for her as an outpatient procedure. So if you're very concerned about it, demand that from your hospital as well. Vaccines and side effects, thank you for raising that. I think it's an important issue. A small number of people do get side effects. That is correct. I think, again, the messaging from government and the JCVI has been unfortunate, because they have been so keen to counter the anti-vax movement, which is very important, that they have said, oh, they're totally safe and there's no side effects. And then people get side effects from vaccines, and then they start believing in conspiracy theories, that we're being sold a lie. And that is why the honesty in this is so important. Thanks, I'll stop there.
Thanks, Jonathan. Gary.
Yeah, I'm just going to put a question to you, Jonathan, because I think this is quite an interesting one, being it's summer. Everyone's being encouraged to keep their windows closed, etc., over the summer because of the heat. Now, obviously, we're enclosing, I would imagine, particles into the home then, once you do that, but although we're trying to keep the homes cool. So what would you suggest really that should be the right approach to that, being that the temperatures are up in the 80s and possibly 90s in some cases?
Thanks for that, Gary. Nice to see you again.
And you.
Yeah, important question, because thermal comfort is important. And, in workplaces in particular, and for vulnerable people, elderly people, small children, heat exposure is a real problem. And there are deaths. Every time there's a heat wave, there are several thousand deaths in this country. So it's not a small problem. It's difficult, because how do you balance the risk of getting heat stroke, say, against getting infected with a pathogen like COVID-19? What the aerosol scientists say is that opening windows can help, but it's very much a second class, if you like, mitigation measure. Because the thing is, if it's very hot and there's no wind, even if you open the windows, well, I was going to say, if you open the windows, the air doesn't move, and therefore whatever virus is in the air doesn't get dissipated, it doesn't get diluted. Closing windows and closing the curtains can lower the temperature indoors. So I think the answer is air filter units, which will clean the air of virus in that space. The problem is you've got to buy them yourself, but there are fairly economical ones that are available, and there are lots of websites. And if you're on Twitter, there's an organization called Clean Air Stars, for example, which can give you good advice. You'll have seen in the US and Canada, the wildfire smoke. And it's interesting now, photographs of people in New York walking around, loads of people wearing FFP2 and 3 masks, or N95s as they call them. And they work against the smoke. And smoke's a very good analogy because the particle size of smoke is about the same as the virus. And they work for both. And air cleaners will work for both as well. And you have the minimizers and the denialists actually saying to people wearing masks in Canada and in the US against the smoke, don't wear them, they don't work. So, the madness extends to that too. Thanks, I hope I've answered that okay.
Okay, that's lovely, Jonathan. Thanks very much indeed.
Thanks, Jonathan. Joan?
Yeah, my relatives are on the East Coast. They were previously on the West Coast, so they're really good at dealing with smoke. They've got it sussed. They brought their mask with them from the West Coast. Yeah, I just wanted to raise particularly around the booster vaccinations, because first of all, they're saying not many people have taken them up, but actually I only got a leaflet last week to tell me to have one, even though I'd actually had one at the end of April. So I think the fact, particularly with the over 75s, tended to go and get them because we're a very disciplined generation who do these things and actually remember the whole history of vaccination, and therefore tend not to be quite as conned by the myths as some others. Not everybody, but but certainly when I went, it was unfortunately rather too packed, with only half the room wearing masks. And when I said, why aren't they wearing masks? They kind of said, we weren't told you should, was what I was told. Fortunately, I survived that one, and I've survived going to hospital for outpatients appointments and inpatients, in fact, and still have managed not to catch it with 7 vaccinations. But I wanted to raise around the booster what an awful lot of people on the clinically vulnerable families website are raising about carers being excluded this time round for the boosters. And a lot of people are really, really upset because the carers were included in all the previous rounds, and it's just putting them at risk. Because what's the point of going and getting a vaccine if then the person who's coming into your home every day, and we all know the kind of stories about poorly paid carers and only wearing masks and everything else. But it's really upsetting an awful lot of people that they were included last time, and other family members as well, but it is particularly carers who were included last time, and yet they're going to cut off, having sent out the leaflets last week. There will be no more boosters after the 30th of June. And so not only have they kind of taken away all mitigation measures in terms of physical mitigation, but they're also clearly now, despite having supported a vaccines only policy, are now kind of going into not actually providing the vaccines either. And I was wondering whether, included with the masks in healthcare, whether the fact that particularly the carers issue is also a good one to be campaigning on, that whilst I actually think, everybody should be entitled to a booster vaccine if they want one, regardless of age or kind of infirmity, at the same time, excluding people who had it previously is clearly a really, really big problem and very, very worrying for a lot of people. So that's the one I wanted to raise. But thank you, Jonathan. Lots of other issues I could raise, but that one is sliding past, and we need to look at a way of how we campaign on that. Thanks,
Joan. Do you want to come back with that, Jonathan?
Thanks very much, Joan, and John too for raising the vaccine thing. And as John says, the booster program is extremely limited. Over 75 clinically vulnerable. And it's just totally inadequate. And as you say, it's coming to an end soon. And the other thing clinically vulnerable people are saying and communicating in distress is they go to a vaccine center, having called up beforehand to ask for people to be masked, and nobody's masked. And they told the same thing. Oh, you don't need to wear a mask. Why don't you take yours off? Kind of thing. And people have been really distressed. And some have gone home again. And some have gone home from A&E departments because of the lack of masking. So I would agree with you that, you know, carers of vulnerable people are an essential group. But, you know, the vaccine program has never made sense. You know, when it was first rolled out, at least it covered the majority of the population. But I remember very clearly when JCVI, you know, prioritized vaccines, and they did it on death rates, on crude death rates, which was the elderly and clinically vulnerable people. Fair enough. But then when you compare the death rates of essential workers, like security guards and bus drivers and Uber drivers and people like that, their death rates were well in excess of clinically vulnerable people who had COPD and asthma and diabetes and things. Not to say those people shouldn't get it, of course they should. But again, there was this these decisions that were taken that were very patchy and had no logic to them. Now, why, for example, are children not being vaccinated in this country? In the US, they're vaccinated, in many other countries. We know how important schools are. We know what COVID is doing to our kids. For the life of me, I'm so grateful that I don't have children of school-going age. If I did, I don't know what I would do. I'd probably be in that group of parents, keeping their kids at home and fighting a battle with the school, stopping them, taking me to court for not sending my children to school to get infected and reinfected again. And I really, really feel for families. So there's no logic to it. And it, you know, overall, I think what's driving this, and I'm quoting here from infection control people who say, nationally, it is recognized that we are not going to be able to control transmission. Therefore, we're going to treat COVID like any other respiratory infection. Now, COVID is not like any other respiratory infection in terms of the damage it does and in terms of the repeated infections. No other respiratory virus does this. We get flu once a year. We can get COVID 2, 3, 4 times a year from now on, and all the damage that it does. So that, to me, is a surrender. And it's an acknowledgement where what they're doing so far has failed. So instead of saying, let's look for other means of stopping this pandemic, in their arrogance and blinkered way of looking at the world, they refuse to work with airborne scientists, aerosol scientists. They refuse to work with ventilation engineers and include them on committees that draw up the guidelines. And we've looked into this in great detail. There is not a single ventilation engineer on the expert committees that draw up the guidelines for infection control. Even the committee that looked at aerosol generating procedures. No aerosol scientist on an aerosol generating procedure subcommittee. It's madness. It's crazy. Thanks.
Thanks for that, Jonathan. Joseph and then Paulina, and I will have to leave now, I'm afraid. Joan, if you can take over. Thanks a lot. And thanks again, Jonathan. Brilliant. Thanks a lot. Bye.
Can I suggest we take Joseph and Paulina one after the other and then you reply, Jonathan? Joseph?
Yeah, thank you, Jonathan, for a very interesting talk. There are 3 quick points I wanted to raise. One is about why there hasn't been more reaction from the public. I mean, I was quite surprised that the petition is still languishing on 5,000. I mean, I know that a lot of people have been gaslit and so on, but still one would expect more reaction. Do you think that a lot of people have just given up the ghost, really? The second thing is something you touched on earlier, is about the reasoning behind all of this. I mean, you just explained the madness, but there also seems to be an Orwellian method to it, because by removing things like data, I mean, Orwell's view was that if you remove the terminology, you remove the concept. If you remove the data, and the latest thing I've seen is that the European data about excess deaths over the last few years. It's now been altered so that the excess deaths are now only over the last 3 years, which makes it look, normalizes effectively the increase in excess deaths. And finally, on the issue of clean air, I mean, Belgium has managed to pass clean air legislation, and now I believe all the indoor spaces and public buildings in Brussels have HEPA filters, the theatres, cafes, everything. So, I mean, if Belgium can do it, why can't the UK? Again, it comes back to just a lack of any political will.
Helena, you had your hand up before. Do you still want to ask a question?
Yes, please. Sorry, it must
Take
down.
Helena, Jonathan, before you come back.
Yeah, sorry, my camera's off for some reason. But I just wanted to draw attention to a particular thing, because I work with the long COVID support charity, and we have a lot of, especially, you know, in medical professionals constitute a very large group within that cohort of people with long COVID. And from our various surveys, we found, and you know, it's the same with ONS figures, that people working in health and social care, you know, they make up around a third of people with long COVID. And also a third of job losses from long COVID. Our service found that, as we did with the TUC, that 1 in 7 people with long COVID have lost their jobs. And we're seeing increasingly doctors and nurses being pushed out of their work via various means. But while the Industrial Leisure Advisory Council has advised to recognize COVID as an industrial disease, they have refused to do so with long COVID. So that's quite a significant point. Another one is, again, people who long COVID does not recognize this, and they're not clinically vulnerable, and the whole clinically vulnerable list now has shrunk to almost nothing. So even people who were previously considered clinically vulnerable, you know, with severe asthma or COPD, or with, you know, with various illnesses, it's now shrunk to bare bones. And again, the surveys and research so far has found that that repeated infections cause people who already have long COVID to deteriorate, apart from the fact that people develop long COVID for the first time with subsequent infections. So they might have had an infection before where, you know, they recovered and were fine, but on subsequent infections, they might develop, you know, long-term symptoms. So that's another issue. And the case, okay, you know, like everybody else, they're encountering this situation where they can't get vaccinations, and they can't persuade colleagues, or you know, when they need healthcare themselves, other healthcare professionals, to wear masks and to protect them. So it's a kind of constant uphill struggle. And you know, pretty much every week we hear from somebody losing their job, and that's basically the situation. I don't know.
Okay.
All right, Jonathan, do you want to come back on those two?
Yeah, sure. Thanks very much, Joseph, and nice to meet you finally online. The public reaction, yeah, it's a puzzle, isn't it? The only way I can explain it to myself is that it's testimony to the extraordinary effectiveness of the information war that's being conducted by the powers that be. You know, they have the mass media. Unfortunately, they have a substantial number of enablers in the scientific and medical community. And I think that needs to be recognized. Some of the worst minimizers, in my view, have come from the medical profession. Not all. And I think what's happening within the medical profession is, I think there's a lot of disquiet, but I don't think people say very much, not in public, because they're afraid of the consequences. And I would point you to the consequences for whistleblowers in the NHS, of things like patient safety. The latest example being, I think, the Brighton, I think a couple of Brighton hospitals, 2 surgeons, whistleblowers, patient safety. driven out of their jobs, hounded out and victimized. And it makes me think, you know, where is the accountability for NHS managers? Where is it that visit all of these things upon patients and healthcare workers, and they are never accountable for their actions? So the other thing is, I think there's a lot of behavioral psychology going on. In fact, you know, this notion that when everybody around you is wearing a mask, you're much more likely to wear one, and vice versa. And I think that all operates. And there have been a lot of surveys that show that the majority of the population are quite willing to wear masks in crowded spaces. And very interestingly, within that, the groups that are worst impacted by the pandemic, the elderly, and interestingly, Black and Asian communities, the numbers of those people who say they're willing to take precautions, including mask wearing, is significantly more than the white majority population. And that I think explains a lot about, you know, who's getting hit hardest here. Why is this happening? And you know, you refer to the removal of data and the massaging of the figures and the manipulating of statistics and the excess death figures now being 3 years. And even if they didn't make it 3 years, you know, that when in year 4 of the pandemic now, and even the 5-year limit for excess deaths is starting to capture data from 2020 and 21. So that is going to skew those figures. Be interesting to have another metric which looks at deaths, you know, and excludes the pandemic years, but then that becomes complicated because, you know, what's happening out there changes. You know, the austerity and the standard of living and the cost of living crisis and all of that also impacts adversely on health, you know, which are called the social determinants of health, as people here will probably know about. And there is a real crisis, and life expectancy is falling, in large part, I think, due to COVID, but I think also because of poverty and deprivation and lack of access to the NHS and so on. There's a very interesting sort of notion or idea, which I really like, by somebody called Ruth Gilmore, who's a campaigner and a writer in the US. And she talks about organized abandonment in relation to poor Black communities, chiefly in America. And it's been going on for decades, obviously. And I think this is what this government is doing. This is organized abandonment of the population at large. They know that their class allies, if you like, or the same people in their social class, the well-off, will not be anything like as impacted by the pandemic as the working class and Black communities. And the running down of the NHS and poorer communities and the whole COVID infrastructure is a deliberate policy, in my view. They're not impacted because who would have to spend money to clean air in public places? Industry, business, and government. And they're not prepared to do that. Paulina, thanks very much for your comments. I don't think there was a question in there, but I'd really like to see the work you've been doing, and would be very grateful if you could share that with me. I just wanted to add, in relation to vaccines, if you want to see the latest on who's getting vaccinated and who isn't, have a look at the Independent Sage briefing from last Friday. There was a good explanation of who's getting vaccinated and who's getting further and further away from vaccine coverage because they're not eligible for boosters. Thanks.
Right. I've got, there was a question in the chat a while back, which I'll just read out from Joe Woods. Is the amount of viral load still considered important? For example, if you inhale fewer airborne particles in a better ventilated room, does it result in a milder infection? You got that one, Jonathan? I'll take Carol next before you answer that, but I thought it was getting lost in the chat. Carol. Carol Morley? You're on mute. You've got your hand up. Yes, no? Right, I'll take Terry Harper then while Carol works out what she's doing. I'll come back to you in a minute. Terry.
Thanks, Joan. And thank you, Jonathan. Really very useful talk. I wanted to ask two questions. The first is about sewage measurement of viral load and stuff. Is that still going on in the UK? I listen to South African radio every day, and it's reported on at least once a week and has various people phoning in to comment on it, and it's kind of kept alive, even though testing has gone right down. And then, so I wanted to know if it's still around or if it's, no, okay. And then my second question was about, I've been thinking about this social determinants and all the, you know, who wears masks and who doesn't at work and so on. I mean, I work in an NHS trust and nobody wears masks except me, if it's an in-person thing, meeting or something. And certainly not at the desk, nobody wears a mask, and finding the same amongst nurses in hospitals. I was just thinking back about some years now before drink driving became illegal, and how so many people used to drink drive until they were banned for a year, and it all suddenly came in that, you know, and even the most sensible people, even doctors, used to drink drive. I have some in my family, and they, you know, had a year's, and that was it. That was the end of drink driving, as far as I was concerned. After that, nobody drank and drove. So I just wondered if there, you know, with the hospitals, certainly with going for outpatient and A&E, you know, appointments, whether we could have a campaign to try and at least, as you say, protect hospitals or GP practices, or some small thing that we could try and achieve. I mean, tubes and buses are going to be a no-no, I realise. But so I just wondered your thoughts about that. Thanks.
Would you like me to answer, Joan?
Yes, answer that. We're trying, Carol's having problems unmuting, so we're going to try and sort that out.
Okay. Joe, thanks very much for your question. Nice to see you again too. Is viral load related to severity of disease? I mean, logically, one would think so. The problem is that Omicron is so infectious now that it's difficult to know. I think in the early days that was true. There's no doubt about it. But, you know, there was a comment by Stephen Griffin on Independent Sage a month or two ago, maybe been a bit longer, in relation to long COVID. And he felt that sort of the infective dose wasn't that important in terms of coming down with long COVID. I don't think it changes what we need to do, though. We need to clean the air. And if we clean the air properly and we wear masks, the risks and I think the rate of infection will go down. There's no question about that. Look, this virus is still airborne. And if we get, you know, the thing about air filters and FFP3s is they are incredibly effective. It needs everybody to do it, and it needs good ventilation, and it needs adequate amounts of clean air delivery rates, so-called, for the air filters. But if we do that, we can get rid of all the infectious aerosols. So it is doable, but ventilation on its own is not enough. And the aerosol scientists are very clear about that now. They're talking about ventilation plus air filtration. And the other measure, which you'll probably know about, is UV light. Although that's a bit more complicated because it does have the potential to have health impacts in terms of producing ozone and other harmful chemicals in the air. But that technology could be developed, and when it is deployed in a safe manner, it's incredibly effective. It just wipes out the virus and many other microorganisms straight away. Terry, hi, nice to see you too. Sewage, yes, it's going on in Scotland and Wales, not in England. And again, if you look at Independent Stage from last Friday, they did put up the numbers for sewage monitoring. Scotland's going down. They said that Wales is going down, but if you look at the curve, it's actually going up a bit. But we are in a bit of a trough at the moment, which is great. Long may it continue. You know, the better weather, and it looks like transmission is going down. Hard to know where we are with all the data disappearing, of course. And unfortunately, I think it's inevitable that another increase is on the cards. I don't think we're ever going to see the huge waves we saw in years 1 and 2 because of the changing immunity pattern from vaccination and infections. But you know, the baseline numbers are really concerning. They've dipped below 1 million now. I think they're about 750,000 according to the Zoe app, but the accuracy is getting increasingly unreliable. But you know, that sort of number going on, there's more and more immune evasive variants happening, and the reinfection on top of that. Masks in the NHS, absolutely, people have stopped. I would say to all of you who wear masks, please carry on, stay strong. Do stay strong. It's really important that you're visible when you go out. I hope nobody's had mask abuse. If you have, report it. If you feel strong enough, contest it and share it on social media, and get onto social media and join forums where other people think the same. There's a great deal of solidarity on social media, and try and direct other people towards it as well. It's really important. But I'm glad you've raised the issue of campaigning. And Joan, I don't know how much time we have left. I can stay on a bit if people would like to, but it would be good to talk a little bit about what practical campaigns we can actually start to think about. I mean, you mentioned vaccines for carers, which is a great idea. I think something like a local demo would attract press publicity. I think the healthcare campaign, and I would urge you to all support it, is promising because it's much harder for them to argue back at. And I think attacking the clinical guidelines. I think is very important. So if we do have a bit of time, it'd be good to see what people would like to campaign on, and how much support there might be for something like a demo and taking these other campaigns forward. Oh, just quickly, sorry, before I finish. Drink driving, absolutely. You know, measures were taken and it stopped. It's the same with passive smoking. Do you remember the adverts? You know,
seatbelts.
Well, seatbelts and passive smoking. What was the advert? Most doctors who smoke Camels, right? And all that nonsense. And what happened? I think healthcare was the first place that they banned smoking because of the passive smoking risk. And the analogy with smoking and drink driving, seatbelts, etc., is a good one because they are public safety things. And we never say to people, oh, only people who are, you know, physically impaired shouldn't drink drive because if they have an accident, it'll be worse for them. Or people who are clinically vulnerable should not be exposed to passive smoking. You do these public health interventions for the whole population. That's what public health is about. Individual public health is a nonsense. It just doesn't exist.
Now, before we finish, I've got Anne Galpin's got her hand up. Carol's having problems, either tech problems, which normally I'd suggest she leaves and come back, but at this time, I think she'll either have to put her question in chat or give up for the evening. But Anne, do you want to?
Yes, thank you very much. Jonathan, would you be able to give some tips for, I sort of help organise one of the evening conferences for disabled workers. So obviously there will be, I mean, not just because we're disabled, but many of us will have, will be people at risk, at higher risk or whatever. I don't know what the common parlance is at the moment, but it's being within, I have this, I feel like I'm now sort of I raise it at every meeting, and not a single other person around the table in the organising forum at the TUC or whatever is. I think, I don't know what pressures have been brought from quite high up at senior levels in all sorts of organisations, including trade unions. I don't know if and I might be in trouble for asking this question, but I really feel nervous. We've got the conference coming up in person in middle of July, and I've said we must have, you must talk to the conference centre about safety precautions, but I've never had any feedback, and I don't know how to. I've got a meeting on Wednesday, which is my last opportunity to really flag it. And if it be possible to, if anybody on this call wanted to exchange emails so that I could try and get some notes, it would be really helpful, because I'm not an expert. I'm just a disability campaigner. So I really need some hard stats or something very succinct. And what better room to ask than here? So I'm
going to suggest you contact Janet at Hazards.
Yeah,
I know has done a lot of stuff on that.
Yeah, I know, but we still feels like we're singing in the wilderness. It feels like singing in the wilderness. Like,
I know we've campaigned really hard for hybrid meetings and not just kind of in person and safety ones. But I know Janet's done. I think she's got some documents that she could send you. So if you need to, let us know if you need her contact details. I think you may have them. Have you, Janet?
Yes, I have. Janet at Hazards. Yes, I have. I'm just
yeah,
really
she's
worried,
the best person I can think of.
But I'm also really worried because people are in such desperate to actually see people in person again. People are taking risks.
Yeah, I know they've done kind of quite a long thing about what you need to do to make the room safe. So that's the best I can think of. But Jonathan, somebody has asked for your Twitter handle. So if you
I'm not on. Oh, Jonathan, I'm not on Twitter.
Yes.
Sorry.
No, I'm not.
Sorry.
So if you could put it in the chat, Jonathan, if you could do that. And before you wind up finally, let me find Carol's question that she was trying to ask. Why the eye protection hasn't been mentioned, like DIY goggles, for a long time? Are they not needed now? And she says her partner stays in the flat for 4 days every time he mixes indoors. So what's your view on goggles? I think then we can try and wind up. I would like you to recap what you said earlier as a possible location for any demonstration, because one of the discussions we had on the campaign is whilst Scotland did a really good one about masks, they've got the Scottish Parliament is quite a good focus, whereas here it's quite difficult to find the best place that that gives it a focus, other than going to the commemorative wall, which obviously is quite good for a photo shoot, but actually kind of getting to anyone who may be a decision maker is a bit harder than that. And if we want to do more than a photo shoot, I know Sue particularly, because she's involved in the independent inquiry, they're kind of demonstrating on various things and whether that location may be a good one. But no, you did mention a place in Waterloo earlier, so maybe let's try that again. But yeah, if you could answer the kind of last bit of questions and particularly focus on, as you say yourself, what action we could take, then clearly the COVID Action Steering Committee will look at whether we can organise something, obviously as jointly with as many other campaigns as possible, because we're pretty small and there's lots of other people who feel quite strongly. I mean, the numbers on this call, which is quite impressive at this time of day in this heat, it has been good, over 50 at one point. So obviously there's a lot of people still really, really concerned about it, and it's very obvious from social media, from anyone who has got vulnerabilities, that they're really concerned about it. So yeah, if you'd like to kind of sum up in answering those last couple of questions, that'd be really good. Thanks.
Thanks, John, and thanks for the questions. The goggles are tricky. Theoretically, yes. The eye's covered by a mucous membrane, and the virus is airborne, and we were talking about viral load and how infectious Omicron is. So theoretically, I think there's a risk. But I think that in ensuring you've got an FFP3 mask with a very good seal is more important. Now, if you've got that and you want to add goggles too, then fine. And I think, again, anything that seals around your eyes, that's fine. And you've probably seen in hospitals, they use these PAPR hoods, which completely cover your head. And they've got a visor and they've got fresh filtered air that comes through, and that gives them total protection. So I would concentrate on protecting the respiratory tract, your mouth, your nose, and get a really good seal around your mouth. I think the risk of eye transmission is there, but I think it's small in relation to that. Just coming back to your point, Anne, I'm glad you've raised this. I think a couple of people have mentioned that there is this guide that, in fact, Doctors in Unite and Hazards produced together for conferences, a safe conference. It's on our website, and I think it's on the Hazards website as well. If it's a short time to go, it may be too early to do it. But I would encourage you not to stop shouting about these things or rather demanding proper protections. I think we've all done it and we've all had pushback. And I know Joseph, who's on the call as well, has done some work within Unite and pushed quite hard for Unite to take it up. I'm glad to say that our new National Health and Safety Advisor within Unite is very sympathetic to COVID protections, and we are working within Unite to progress this. I've raised it at TUC meetings as well, and I would keep pushing it. And if you have a CO2 monitor, I think that's a great little device. I don't have mine to hand, but if you have that within the meeting room, that can help keep you safe. And I know that, in fact, there was a TUC Southeast Region meeting that was postponed the beginning of the year because the organizers didn't feel that it was COVID safe enough. And I know that the ventilation, if this conference is at TUC HQ in London, I think the ventilation may be good enough to have a relatively safe conference. But I would encourage the delegates to mask, try and measure the CO2 level if you can, have a look at that guidance and keep pushing it. Okay, so just to finish then, thank you very much again for having me speak. It's been a real pleasure to be with you all. I'm glad to hear that there is an appetite to keep fighting. I think we should go onto the offensive about mitigations in healthcare. Let's really push hard on it. You know, we have the facts on our side. Like, I can hear some of you thinking, yeah, but that's the same with every campaign. It's true. But I think hospitals and healthcare are a particular area where we will have public support, and it's much harder for them to argue about this. Maybe what we could do, or talk about, Joan and other people who are on the call who are interested, is to perhaps call an organizing meeting for a demonstration here in London, and maybe in other parts of the country if there's appetite for doing so. And I'm sure that my colleagues in the campaign, COVID Safety Pledge campaign, and Doctors in Unite would be happy to take part in that. And we can look to other organizations as well to build maybe a demonstration, and to perhaps look at what else we can do within healthcare. And I know clinical vulnerable families would be very interested in that, so that we have actually a campaigning group which can take this forward. Because I think it's important that we don't have 5 people standing outside a doorway on a busy street in London. I think that's fine, but I think we need to have a kind of a good presence which makes a fuss and gets noticed and gets some media attention, because it's an important issue. And if we don't get that, I think it might be better to reserve our limited resources for something that's more effective. So I'll stop there, save just to say, carry on fighting the fight, people. This is really, really important. History is on our side. The naysayers, the minimizers, the denialists will be seen as the mad people that they are, compared to those in 1854 who resisted clean water. And there's a fantastic leading article in the Times newspaper, which says, leave us alone. We don't want to wash our hands, and we don't think it's worth getting rid of excrement and having sewage in place. Just forget about it. It's not worth doing, okay? Don't bother us. And it's that kind of nonsensical, unscientific dogma that we're fighting with clean air. The other thing I think we should think about, this is my final point, is let's make common cause with the clean air campaigners.
I was going to say that as well.
and climate change campaigners. I'm glad to see there's a coming together of this now. And I see that the all-parliamentary group on clean air, on air pollution rather, increasingly talking about clean indoor air.
Yeah.
So I think we've got lots of allies. The problem is we're all atomized and not together. I think we must start bringing people together and start to organize and to start to campaign together rather than in these silos. So thanks very much again. It's been a great pleasure being with you tonight.
Thank you very much, Jonathan. That was excellent. And yes, we will take up the idea of trying to organise some kind of organising meeting and put it in the newsletter so people know that we're doing that. And I certainly agree with your last point about linking up with clean air inside and out. I live on one of the most polluted corners of London. I get it in every direction. If I open the windows, it's more polluted than if I keep them shut. So, you know, but thank you everybody for coming. This was one of our better attended ones. So thank you very much, Jonathan. You've obviously a big draw to people wanted to hear what you wanted to say. Thank you very much. And thank you everybody for coming.
Yeah.
If anyone wants to info on contacts and things, if you email us at info@covidaction.uk, then we'll pass it on.
Joan, do you think you could save the chat? Because I think there were a few.
Yes, it will get. It automatically gets saved anyway. So yes, yeah. Brilliant. But I'll pass it on to you if you haven't saved it yourself. It's easy if you save it. There's 3 little dots.